I'm really honored to be here, and I thank you all for the invitation. I hope what I have to share is helpful to you as we take care of our patients together. And if so, to God be the glory. This is updates in DMARD therapy. So DMARDs, being the disease-modifying antirheumatic drugs, is a large group of medications that we refer to as DMARDs. These are medications that have been shown to be able to put our autoimmune conditions mainly into remission and hopefully keep them there. Oftentimes we refer to them as steroid-sparing agents. This is my clicker. And so they're, really important, and we have old and we have new. And let me see if I can click this ahead then. I have no disclosures. Forgive me, but the clicker is the top button, or? Yeah, that's what I thought, but it's not. Okay. So we'll start with a case. DS, she's a 57-year-old female with a history of plaque psoriasis, also has diabetes, and came to me to help with management of her chorioretinitis that she's had since about 2010. She has a long history of right eye scarring by the time I saw her in 2021, and they were dealing mainly with her left eye inflammation, which had started in about 2019. She had been treated with a number of ocular therapies, and even oral prednisone for about a year in 2010 to 2011, which was associated with about an 80-pound weight gain. She had had quite a workup, including all the serologies for autoimmune conditions and infections as listed here, and none of which were positive, likely associated with her psoriasis is the thought. Her past medical history was notable for congestive heart failure. She had complete heart block in 2011. She had a decrease in her EF, and she had metabolic syndrome and the TIA as well. Her medications were the usual kind of polypharmacy to treat the above conditions. She really didn't have many other complaints. She did admit to having some chronic low back stiffness, but otherwise no other autoimmune features. So given that history and wanting to treat her chorioretinitis, which one of these is contraindicated? A, adalimumab, which is an anti-TNF. B, secukinumab, which is an anti-IL-17. T, tocilizumab, and IL-6. Or D, none of the above, that you could entertain each of these. And this is just, you can kind of consider it in your own mind, or if anybody wants to shout it out, it's all good. So the answer is A, adalimumab. As an anti-TNF, it is contraindicated. TNF inhibitors are contraindicated in congestive heart failure, particularly class 3 and class 4, but congestive heart failure being on a continuum, I think it's best to avoid, and especially since we generally do have other options. So this is a really important thing to keep in mind. And indeed, this patient's cardiologist really did not want her to be treated with adalimumab or any TNF, of course. So we did treat her with tocilizumab, and just a word on that. And I want to thank Dr. Baykal. Did I get your name? Yeah, you did a fantastic job, and I already talked about some of that. So a little repetition will just really make everything so solid. Tocilizumab is an IgG1 monoclonal against the receptor. It was FDA approved roughly about 10 years ago for rheumatoid arthritis, and then about 5 years ago, very exciting that it had an indication for giant cell arteritis. It was the first FDA-approved medicine for that specifically, and especially as a biologic. That's just really, it was really exciting in our world. Also used for systemic sclerosis-associated interstitial lung disease. Has uses also in JIA, which I'm just an adult rheumatologist, but certainly that's really important, obviously. And it has been used, interestingly, for cytokine release and in COVID-19. Has shown some efficacy in refractory uveitis, macular edema, so very important. The dosing is 162 milligram auto-injector, can be weekly or every 2 weeks, depending on the situation, and the IV is 6 milligrams per kilogram. Sarilibumab is another IL-6 inhibitor, which also initially approved for rheumatoid arthritis, continues in that, of course, and then in the last couple years, excitingly, approved for PMR, which is like the first FDA approval for that condition specifically, and then, of course, the association of there with giant cell arteritis, I thought that may be of interest as well. It has been used in COVID-19, not as a first line, but that's interesting as well. And just for completeness, satralizumab is another IL-6 inhibitor. It is for neuromyelitis spectrum disorder. So as is the case with all our medications, monitoring is of the utmost importance, and for what is kind of called the traditional DMARDs, kind of basically methotrexate, sulfasalazine, leflunomide, maybe Imuran, mycophenolate, the monitoring with checking for hepatitis B and C ahead of time is required, and we check cell counts. I generally, for all of those medications, check a month after starting a new medicine, and then the maintenance is every 3 months at the very longest duration. But biologics also need to be screened for tuberculosis initially before it should be administered, and yearly. Lipids can be affected by the IL-6 inhibitors, and so checking a couple months, within a couple months after starting it, and then every 6 months is reasonable. Keep in mind that can affect the bowel, as was mentioned, some GI side effects. And then Dr. Bakal did cover the JACTA trial nicely, and it was just really exciting. Again, we're just trying to get patients away from the steroids. The steroid-sparing effect is just of the utmost importance, and so this study where they did weekly versus every other week, they were really able to show nicely the ability to taper that off. There was one case of anterior ischemic optic neuropathy in the tocilizumab every other week group that was treated with steroids and did respond to that, but that was just kind of interesting. The placebo group actually had a little more infection, which is a nice, interesting reminder that steroids are a risk for that as well. And the long-term treatments are looking good as well for folks who flare after a couple years. The reinstituting tocilizumab has been helpful as well. Studies for uveitis specifically, there's a multi-center randomized open-label controlled trial, the STOP uveitis study. Smaller numbers, of course, but 37 patients were randomized either to the 4 or 8 milligrams per kilogram dose for a monthly for 6 months, and both doses had improvement in vision, decreased vitreous haze, and central macular thickness edema. There's a retrospective study that I listed here, and 16 eyes from 12 patients with uveitic macular edema, and the central macular thickness improved in a good number of those. A few words on seralutinib, the one that was just recently approved for PMR. That approval came basically from the SAPPHIRE trial, a multi-center randomized double-blind placebo-controlled study looking at patients who were not able to taper off the steroids. Again, that's kind of our main focus. The 52-week study of seralutinib, 200 milligrams given every 2 weeks, plus a steroid taper by 14 weeks versus a placebo every 2 weeks and traditional 52-week taper. They weren't able to recruit as many patients due to COVID. They only had 118 patients that wanted 180, or 280, sorry. 78% completed the treatment. They had sustained remission at 52 weeks in the seralutinib group at 28% versus 10% in the placebo group. Seralutinib had 44% lower risk of flare after remission, which is nice to see. They did have some neutropenia, which certainly can be an effect, and again, the monitoring is of the utmost importance. But the frequency of adverse events seem to be more common in the control arm, and it's mainly infection. Again, just another reminder that steroids are not benign. So here just some summaries of their endpoints, which was really nice to see. The orange, of course, being the seralutinib arm. They were able to have sustained remission at week 52. Remembering that IL-6 affects CRP, so kind of taking that out was interesting to look at as well. And then the successful adherence to tapering steroids, such a focus for us. Okay, so switching now to IL-17 inhibitors, which can be considered just kind of along the lines in our patient here. Secukinumab is also a monoclonal inhibitor of IL-17A. It comes in injection only, 175 milligrams per mil sub-Q. It was originally approved for the seronegative spondyloarthropathies and psoriasis alone as well. Psoriasis sometimes needs a higher dose, and that's why you'll see that there. And sometimes people need a loading dose. Oftentimes they do, and if you can get it approved, that's ideal. Sometimes that's a bit of a challenge, but it's 150 milligrams shot weekly for 5 weeks. There's also a phase 2 trial in giant cell arteritis, looking at the 300 milligrams secukinumab or placebo weekly for 5 weeks, and then monthly for 48 weeks. This is also including patients who are already on steroids, of course, varying from 25 milligrams a day to 60 milligrams per day with a taper plan there as well. The primary endpoint was sustained remission through week 28. And 27 patients completed this and 25 in placebo. At week 28, there was about a 70% remission in secukinumab versus 20% in placebo. And at week 52, had 50% remission to secukinumab versus 8% in placebo. Adverse events were about 22% in secukinumab versus 44% in placebo. Again, these are mostly infections, so these studies are just, I find that just really remarkable and interesting. So they do have an infection risk, but yet it works well to target, I think, maybe just one part of the immune system. Ixekizumab is another IL-17 that's commonly used as well, 80 milligram sub-Q injection. It also is approved similarly for psoriatic arthritis and seronegative spondyloarthropathies. This non-radiographic spondyloarthropathy is kind of just a subset where people seem to have axial involvement, but it's just difficult to see on imaging. And there are some case reports of the ixekizumab with success in giant cell arteritis. So I think it's exciting. This may be something, hopefully more data on this, that these may be additional options in giant cell arteritis, for example, as well as uveitis. So just some words about anti-TNF. These are just really important medications. These are the 5 brand name, I guess you could say, TNF inhibitors. The first one that came out was infliximab, came out in 1999. This IV only. Etanercept, fusion protein, came out a year later. Adalimumab in 2003, and the other 2 a couple years within the decade. Again, these are contraindicated in significant congestive heart failure, and also contraindicated in multiple sclerosis, as it can make these conditions worse. Again, baseline screening for tuberculosis is of the utmost importance and is required, won't be dispensed without it, or shouldn't be. Hepatitis B and C screening is of the utmost importance. And again, yearly screening for TB. I actually have a patient now, a young college gal, who's been taking infliximab for several years since she was a kid, and she now has pulmonary TB. So yeah, I have great respect to screening that yearly now. Or a deeper respect than I always have already had. So, but concomitant methotrexate is oftentimes used both to have control of the disease, whether it's rheumatoid or uveitis or some of the other indications. Methotrexate can also be helpful to reduce the incidence of the antibodies that can cause a lupus-like syndrome in these medications. Etanercept doesn't seem to be as much of an issue with that. It tends to be more the monoclonal antibodies, but any of them can do it. Infection, of course, is the greatest risk with these. So just specifically on adalimumab, this is a fully human monoclonal antibody, so it was really exciting when that came out in our field. That was the first fully human antibody that we were using at the time. It does have the indications listed there, but specifically on uveitis, it's considered first line for Behçet's and JIA. This came mainly from the visual trial, where you're looking to time to treatment failure at 24 weeks is what occurred with the medication versus 13 weeks in placebo. Visual 2 had the mean time to failure at 18.3 months versus 8.3 months in placebo. There's a long-term extension of that as well, which was looking favorable. There was a study by Fabiani, 64% resolution of retinal vasculitis after 3 months, and 95% were free of active vasculitis after 12 months in Behçet's. Again, the other indications, it was initially for rheumatoid, also psoriatic arthritis, plaque psoriasis, Crohn's, ulcerative colitis, and it has an interesting indication for hidradenitis suppurativa. It's generally 40 milligrams subcutaneous injection every 2 weeks. I have a number of patients who need it weekly, and I'm thankfully usually able to get it, which is surprising to me. But there's some data that it may be more effective than infliximab. In these entities here, as far as anterior vitritis and anterior chamber inflammation after a year. A few words about infliximab. It's partly made from a mouse protein, monoclonal antibody, TNF. It's first line for Behçet's and JIA, and it is used in most non-infectious types of uveitis. Again, approved for rheumatoid arthritis, ulcerative colitis, Crohn's, ankylosing spondylitis, psoriatic arthritis, and psoriasis. And the nice thing about it is that you do have some flexibility in the dose. Again, always having deep respect for the higher the dose and the shorter the interval, the more the risk for things, mainly infection. But it's generally given, the rheumatoid dose generally 3 milligrams per kilogram, more the psoriatic arthritis and others can be more starting at the 5 milligrams per kilogram dose, starting day 1, then 2 weeks later, then 6 weeks, and then the maintenance is generally every 8 weeks. Switching gears, kind of what's new in lupus is I'm sure you follow our lupus patients primarily maybe with the Plaquenil, but you're seeing other things as well. Voclosporin was recently approved. It's a novel calcineurin inhibitor specifically for lupus with nephritis. It's a 7.9 milligram capsule, twice daily is the dose. It interestingly has a dual mechanism of action in immunosuppression via T-cell activation, and also has an antiproteinuria effect via stabilization of the kidney podocytes. It has a nice pharmacokinetics and seems to have better lipid profile as well, and glucose, so it's kind of nice. It can be given together with mycophenolate, and a study with voclosporin plus mycophenolate and glucocorticoids has been shown to have complete renal response rate with rapid reduction of the proteinuria. Some adverse events can include reduced GFR from the medication itself, so of course patients are going to be monitored closely anyway, but that might require a little bit of a dose reduction. Anifrolumab is another what's new in lupus. It was also recently approved in the last couple years. This is an adjunct for moderate to severe lupus. Doesn't necessarily have to be nephritis. It is a type 1 interferon receptor antagonist. It's a fully human monoclonal antibody. It inhibits signaling by all type 1 interferons. It's different than the previously studied in that it blocks the common receptor subunit. It's a 300 milligram monthly IV infusion. Infection, of course, is always the risk, and particularly zoster is a little bit more noticeable, more prevalent. Just a quick word on a new one here. Avacopan is approved for ANCA-associated vasculitis, which is pretty uncommon for us to get something approved for that. It's an oral C5a receptor inhibitor as an adjunct treatment. This was in the Advocate trial where they had 30 milligrams twice daily plus an oral prednisone taper. Everybody was on background immunosuppression, mostly rituximab, but also some cyclophosphamide followed by azathioprine, which is a standard of care. They had similar rates of remission at week 26, but superior remission in the Avacopan group at 52 weeks. So this was just really exciting to see. Most people had renal involvement, and the strongest improvements were in the moderate to severe kidney disease. Also less proteinuria and fewer hematuria patients were in that as well, and no difference in safety between the two groups. So it was superior at the 52 weeks. This is just incredibly new, so there's a lot more to be done with that, but more to come. Rituximab, on the other hand, has been around for a long time. Initially approved for lymphoma, and then rheumatoid arthritis approval was probably close to almost 20 years ago. Also since then has been used for the different ANCA vasculitis. It does have efficacy in scleritis. I'm sure you have all seen it used. Ocular cicatricial pemphigoid, orbital inflammatory disease, and non-infectious uveitis. It works by depleting B cells, working at the CD20 surface antigen. It induces complement-mediated lysis, B-cell apoptosis, and growth arrest. It does have black box warnings it's important to be aware of. This is, of course, IV infusion only, and infusion reactions, which can even be fatal, have occurred. Pre-treatment with steroids is incredibly important to try and reduce this risk as much as possible, so that should be done every time. Severe mucocutaneous reactions can also occur, even fatal. Progressive multifocal leukoencephalopathy, which is the polyoma, John Cunningham JC virus, is rare, but is possible and is untreatable. So informing your patients is important as well. HBV reactivation is listed on there as well. And so again, screening for hepatitis B and C and tuberculosis must be done prior to starting it, and then routinely as yearly with the TB, and then as any risk factors seem to arise in the history. And then, of course, screening, monitoring of the cell count and chemistry is appropriate, and EKG and HCG if appropriate. One thing I do for the rituximab patients that's unique and is really important is checking the immunoglobulins before reinfusing these patients, because with the B-cell mechanism of action, they really can have quite a decrement in their immunoglobulins and really be a significant risk, and it can be very, very long-lasting. So it's important to kind of keep that in mind if patients are being redosed. Certainly weighing, the risks, the benefits. If you've got somebody with, severe renal disease, for example, they just, if they require treatment, they require treatment. But just keeping that in mind, I think, is important. Just a couple words on JAK inhibitors, Janus-associated kinases. Tofacitinib was the first one that came out about 10 years ago for rheumatoid. and the seronegative spondyloarthropathies has been used in COVID. Upadacitinib came out probably about 5 years ago for similar. It also has an indication for atopic dermatitis. I've seen that advertised, and you may have too, heavily advertised, ulcerative colitis. Baricitinib, also approved for rheumatoid arthritis and has been used in COVID as well, and has indication for alopecia. And it may have some use in non-infectious uveitis. Much more and studies need to be done there, but so far it looks like it could be possibly an option. Black box warnings, mainly significant infections, as they all do. All the biologics do have listing for possible malignancy. The JAK inhibitors, there was a recent study in the last year or so in New England Journal comparing it to the TNF inhibitor, seem to maybe have an increased risk of malignancies. So that is continuing to be monitored, but something to keep in mind, and I do mention to my patients. Also as a black box warning for cardiovascular events and mortality, particularly in patients over 50 with one cardiovascular risk factor. And also risk of thrombosis, so patients who have a history of stroke or blood clot, this is the best to avoid. And they do have an increased risk of zoster. So immunizing patients appropriately is really important. So switching back again to lupus, which of the following has been shown to increase survival in lupus? A, Cytoxan, B, belimumab, C, rituximab, D, mycophenolate, or E, hydroxychloroquine. So think about it or think out loud, whichever you prefer. Hydroxychloroquine is pretty much it as far as shown to increase survival in lupus. And this is probably the main reason why this medicine is so important in rheumatology, mainly taking care of lupus patients, although it has other uses as well. And so I'll just have a case here as well. Now, this is not a lupus patient, but a rheumatoid patient that was referred to me in 2020 by pulmonary for assistance managing his rheumatoid arthritis that he has had since 2010. He'd been managed by an outside rheumatologist, treated with rituximab since 2013, plus hydroxychloroquine since he estimated about 2010. I didn't have records, and prednisone about 5 milligrams daily throughout that time as well. He developed a chronic cough and sinus infections in 2018. He was found to have Pseudomonas colonization and infection in his sinuses. Treated with levofloxacin, he was also found to have low B cells, hypogammaglobulinemia, and inadequate response to pneumococcal vaccine. He's been treated, he was started on IVIG and has been treated with that since that time. Continues to have some waxing and waning symptoms, but never really anything too severe in his rheumatoid, thankfully. His past medical history was really non-contributory. Otherwise, his past surgical history, he did have some sinus surgery. Otherwise, his medications, in addition to that, non-contributory. Past DMARDs, methotrexate, he reported anaphylaxis. Leflunomide failed, as well as 3 TNF inhibitors and abatacept. So case continued. He actually had a fairly benign exam when I saw him, just occasional cough. His SED rate and CRP were actually normal. He had a Vectra, which is a lab panel of rheumatoid arthritis biomarkers. It's specifically for rheumatoid arthritis only, and that showed low disease activity, thankfully. And his labs were really not all that remarkable. He did have a low IgM. Chest x-ray was also good. So what would be the best option that he's got a Pseudomonas infection after being treated for almost 10 years on, 8 years on rituximab? So stopping that, of course, would be prudent. Would you continue the hydroxychloroquine as monotherapy and taper off the prednisone? Or would you continue both of those? Would you start Enbrel and switch there, or continue hydroxychloroquine and prednisone? Would you stop the hydroxychloroquine, continue the prednisone? Or would you stop the rituximab maybe with a thought and maybe return to it while continuing the hydroxychloroquine and the prednisone? So I think it's best to stop the rituximab, of course. I like to continue hydroxychloroquine and taper off the prednisone. We're always interested in getting rid of prednisone. And in his case especially, again, prednisone is an infectious risk as well. And one of the nicest features about hydroxychloroquine is that it's not an increased risk of infection. So we continued him on that, and he continued with his IVIG, and at his ophthalmology screening exam, there was an estimation based on his reported history of taking hydroxychloroquine, and so he was recommended to discontinue his hydroxychloroquine based on his ophthalmology calculated estimated cumulative dose of 2,930 grams. He was taking 200 milligrams daily at the time. So a recommendation for alternative treatment. So since he had failed the others or had a severe reaction to methotrexate, really the only other what's kind of termed traditional DMARD is sulfasalazine. And so I did prescribe that for him because he is CCP positive rheumatoid arthritis, although I never really saw much on exam, thankfully. The CCP is very specific for rheumatoid arthritis. And so I did think some treatment is warranted. He continues to receive the IVIG. I think it's best to avoid the biologics just because the prolonged effect that rituximab can have in his serious infections that he had, especially since I don't see any synovitis in this particular patient that warrants additional therapy, thankfully. Interestingly, he has his hydroxychloroquine still at home that he at one point was telling me he just takes it whenever he feels he's concerned about COVID. So its uses are primarily in our field as far as lupus and rheumatoid arthritis, but it has a host of other things as well, primarily skin. But we use in discoid lupus as well, which is a separate entity, can overlap with systemic lupus, and the subacute cutaneous lupus also a little bit of a separate entity. And a phospholipid antibody syndrome can have benefit from hydroxychloroquine with less thrombosis. That's used in JIA and sarcoidosis, and then these other skin findings. So the retinal toxicity is always the biggest concern, and it is for me. And I will tell you, I don't prescribe more than 500 milligrams a day in anybody, and I will not refill it if the eye exam is not up to date. But there's much to be done in the studies to get a better handle on exactly how much can we prescribe for patients. I know Michelle Petrie has the largest lupus cohort, and she's been studying thrombosis in particular for decades. And she is very much an advocate for checking hydroxychloroquine blood levels. That is her most recent finding, probably in the last 3-4 years, to check it and try, with an effort to try and customize a little more among our patients if we can get something there. So checking the blood in whole blood, there's specific tubes that can be used, and giving your lab a call. It's a little bit involved, and I'm just starting to do this myself. Looking for 750 to 1,000 nanograms per mil is kind of the recommended or the most therapeutic dose. But that is in just a tremendous area of interest, particularly in thrombosis. But the studies that have been done have limitations. It's hard to study. The Kaiser Permanente study was mainly looking at dispensed medications, and so as far as what patients were actually taking, it's difficult to say. So some challenges there. So it's just sort of a smattering of DMARDs, and I'll leave it there for any questions.
Yeah, thank you for the talk. I had a question about the Plaquenil hydroxychloroquine patients that come in. You know, frequently we're asked by the rheumatologist to do screening. At times, some of these patients come in, they've been on, twice daily medication for 5 years. Sometimes they're little old ladies, and, I frequently tell them, the cumulative dose and recommend that they talk to the rheumatologist and see if they can lower it down to 1 pill a day. Yeah. And are you going mostly by symptoms as far as what you're treating with a Plaquenil?
You mean their rheumatologic symptoms?
Right. So, how are they going to know if 1 pill a day is adequate?
Yeah. Well, similar to the lupus, it's hard to say. Maybe one day we'll be checking hydroxychloroquine blood levels in everybody. I don't know, but you have to have somebody that's pretty compliant with just the blood draw, because the blood draw would be right before their next dose, and you have to get someone who's able to do that. So yeah, that's tricky. I think
What are the rheumatologists going by? Are they going by the patient's symptoms as far as giving them a twice-a-day dosing?
Well, I think we put everything together, asking them their symptoms. How are you feeling? How long are you stiff in the morning? How much pain do you have, and where are you hurting? And then we, look at their tender joints and swollen joints and make an assessment with that. And then we have our labs. We look at CRP, and we look at sed rate, and we will send the vector, or some people will. Vector isn't always covered fully, but putting that all together and making a decision. Yeah, but first line for true rheumatoid arthritis is still methotrexate. So I think in rheumatoid arthritis, particularly that disease entity, we're usually trying to control it with those other things if it's significant enough. I have been impressed with how much benefit I can get from hydroxychloroquine, though, and I do consider it relatively lower risk if we can dose it appropriately. Some people can be in remission with hydroxychloroquine alone, which is really nice. And I do, recommend lowering the dose later if we can. Yeah.
Thank you.
Do you have a specific approach that you use for like an HLA-B27 positive patient? I mean,
Yeah, that's a great question. So if they've got axial disease, that warrants a biologic right there, as opposed to just, if they've got peripheral disease, sometimes things like methotrexate or sulfasalazine can be effective enough.
okay, he's on methotrexate and Cellcept. Is that a good combination, or should he be on something else? I have a patient. He just has a horrid-looking eye, and it just keeps going up.
It's just eye disease?
No, I think he has other systemic symptoms too, but I just saw his eye before I left.
And that was his first line treatment?
Well, he'd been on methotrexate, missed a dose because he couldn't get it. Our hospital was out of it, and so he didn't go and get it at Walmart. They wouldn't dispense it. And he flared, and he had like a hypopion. He was looking really bad.
Yeah. What about like TNF? Could he take a TNF?
I don't think so.
He could not, or he just has not? Or?
Yeah, he just kind of comes in intermittently to follow up, which is really kind of bad
that's
too.
the problem, yeah. So
he needs,
definitely the biologics, if you have uveitis, Humira is kind of first, sorry, didn't mean to use a brand name.
Yeah.
It's easier to say than adalimumab, but yeah, or certainly
should be
infliximab,
one of those.
a possibility, yeah.
So, quick question. So, there's a 14-year-old with juvenile rheumatoid arthritis who's been, and I'm not sure what prednisone sparing agent she's been put on, but she ended up developing like tics and Tourette's and things like that. Are you aware of any agents that have caused
Like a Tourette's type of side effect?
Yeah, and just tics that are uncontrollable.
I am not,
Yeah. So thanks.
yeah.
Thank you. Excuse me. Thank you for a great presentation. Thank you, Linda, as a rheumatologist coming to speak in front of a bunch of ophthalmologists, and I'm just want to thank you for that, and also thank you for your service with the Air Force. Linda and I go way back to high school, and I've just always been impressed so much by her. I wanted to ask you, Dr. Randerson yesterday mentioned that some of these agents can take months to get insurance approval. And I was just curious, in the case of a uveitis where the eye is going down the hill, fast, months just be devastating. In your practice with what your patients you're treating, have you run into difficulties getting these medications? And is it in many cases so critical to try and fast track it?
Yeah, so in our institution, I work for Baylor Scott and White. We, a couple years ago, kind of internally got a pharmacist to do the prior authorizations for mainly the outpatient prescribed, not the, she doesn't do the IV ones. And that has helped a lot. That's all she does, pretty much, or most of what she does. So that has been the fastest I've seen. I've worked other places. We were military, so we moved around. I've been a lot of other places, and this is the fastest situation. Anyway, other things along those lines, we oftentimes have samples of some, not every biologic that we have, but we do have samples of adalimumab and a few of the others, so that can be helpful to kind of get patients started. Some are more readily approved than others. I find that adalimumab is usually fairly well covered. So that one, I usually have confidence that we can probably get that one pretty readily. Others are sometimes a problem. The problems that I see sometimes in people who are taking these medications at long term, doing well, and then they turn 65, and then it's a big problem sometimes. So it's just, I don't have a good answer, but we are struggling with that sometimes. Yeah. So. right, well, thank you. Appreciate it.